Good afternoon, everyone. Thank you for the opportunity to present our work. Today, I will discuss a systematic proton planning study evaluating whether combining a multi-leaf collimator MLC with a surface-contacted 3D bolus can improve lateral penumbra in pencil beam scanning proton therapy. This work was performed through a collaboration between Osaka Proton Therapy Clinic, the University of Osaka, and the University of Maryland School of Medicine. Our motivation was straightforward. While PBS provides excellent distal dose conformity, controlling the lateral penumbra remains challenging, particularly for shallow targets where range shifters are commonly required. Well, we have no financial conflict of interest to disclose. PBS proton therapy offers one of the major advantages of proton treatment, that is excellent distal tissue sparing. However, lateral penumbra remains an important challenge, especially when critical structures are adjacent to the target. This issue becomes particularly important in shallow tumors. For these cases, when we have to deal with such cases, we often use a range shifter to reduce the beam energy. The problem then is that the range shifter is mounted at the nozzle, which means the beam continues to travel through air after passing through the range shifter. This additional air gap causes increased scattering and broadens the lateral penumbra. Previous studies, including our own work, have shown that combining an MLC with a range shifter provides some improvement, but the magnitude of improvement remains limited. More recently, surface-contacted 3D bolus technology has been proposed. Because the bolus is placed directly on the patient's surface, it can reduce the air path after energy degradation, that means like range shifter, and may therefore improve lateral beam sharpness. This led us to ask the central question of this study. Can combining an MLC with a surface-contacted 3D bolus provide the most effective penumbra reduction for shallow PBS treatments? Therefore, the purpose of this study was to systematically evaluate lateral penumbra improvements achieved by combining an MLC with a surface-contacted silicone-based 3D bolus. We compared this approach against conventional planning strategies using a nozzle-mounted range shifter, as well as plans without a range shifter. Our primary endpoints were lateral penumbra width and the resulting dose delivered to nearby organ at risk. To answer this question comprehensively, we generated a large set of proton treatment plans under controlled conditions, and we even did that measurements using 2D array detectors. A qubit target measuring 60 by 60 by 54 millimeters was positioned at multiple depths ranging from very shallow to deep locations. For each target depth, we generated plans using conventional range shifters, no range shifter, and 3D bolus configurations. Each of these was further evaluated with and without MLC collimation. We also varied the air gap from 50 to 300 millimeters to investigate its influence on penumbra behavior. In total, 134 treatment plans were created. This design allowed us to isolate the individual and combine effects of the MLC range shifter and 3D bolus across broad range of treatment geometries. We evaluated two primary endpoints. First, that was lateral penumbra width, and it was defined using the standard 80 to 20% dose follow at the isocenter plane. Second, we evaluated dosimetric impact on surrounding tissues using dummy organs at risk. These ORs were positioned adjacent to the target with a 3 mm separation and extended laterally by 30 mm. This allowed us to determine whether improvements in penumbra translated into clinically meaningful reduction in normal tissue dose. Well, this slide summarizes the penumbra results. The first major finding is that combining a 3D bolus with an MLC consistently reduced lateral penumbra across all investigated depths. Compared with conventional range shifter base plans, reductions ranged from approximately 1.5 to over 20 millimeters. Looking specifically at the range shifter positive plans, that means those plans that utilize range shifters, shown in the upper panel, the combination of 3D bolus and MLC consistently achieved the smallest penumbra. Interestingly, even when no MLC was used, 3D bolus frequently matched or outperformed conventional range shifter plans that had larger air gaps. This suggests that reducing the air pass after energy degradation, that means like range shifter, may be at least as important as additional collimation. In contrast, when range shifters were not required, the conventional range shifter negative plans, that means no range shifter in the plans, still provided the sharpest penumbra, even compared to those plans using 3D bolus. In other words, 3D bolus cannot completely overcome the intrinsic advantage of avoiding energy degraders altogether. However, for shallow targets where energy degradation is necessary, like range shifter or bolus, comparably then, 3D bolus clearly offers a substantial advantage. The next question, as said, was whether these penumbra improvements translated into meaningful reductions in dose to surrounding tissues like ORs. The answer is yes. Across the range shifter positive plans, introducing 3D bolus reduced OR doses by approximately 10 to 17% compared with conventional range shifter approaches. Even when comparing MLC-equipped plans directly, adding the 3D bolus still achieved an average reduction of approximately 6.5%. These trends closely mirrored the penumbra findings. Sharper lateral dose follow resulted in lower dose deposition outside the target volume. This suggests that the physical improvements are not merely theoretical, they have direct dosimetric relevance. Our findings, therefore, suggest that combining a surface contacted 3D bolus with MLC collimation provides a practical strategy for improving lateral conformity in PBS proton therapy. The benefit appear particularly relevant in low-energy treatments and in proton systems that do not have advanced dynamic collimation capabilities. Another practical advantage is that the 3D bolus eliminates the need to bring hardware closer to the patient. And that is very important because it reduces the concern about collision risk associated with minimizing the air gap for plan quality. There are also opportunities for future optimization, of course. For example, Previous work suggests that smaller MLC margins may further improve conformity, and these effects should be explored in conjunction with 3D bolus. We also recognize several limitations. First, this study used a systematic phantom design rather than patient-specific clinical cases. Second, neutron reproduction characteristics differ between range shifters and 3D bolus materials, and this needs to be further investigated, especially when we are treating special patients such as pregnant patients or pediatric cases. In conclusion, combining an MLC with a surface-contacted 3D bolus provides a robust strategy for improving lateral penumbra control in PBS proton therapy. And compared with conventional range shifter-based approaches, this combination consistently reduced penumbra widths and lowered those to surrounding tissues. The greatest benefit is observed in shallow target scenarios where energy degradation is unavoidable. These findings support further clinical investigations of 3D bolus technology as a means of improving proton therapy precision and potentially enhancing normal tissue sparing. Thank you for your attention and have a very good, enjoy your meeting time.